So good evening. Good evening all. Very much for I welcome you all on the third NEBAOI classroom on 12th of February 2026. Our expert is Senior Professor Dr. Manish Grover, who is the Senior Professor and Additional Superintendent of SMS Jaipur. He was the ex-secretary of the Cochlear Implant Group of India. He did his MS ENT from AIIMS New Delhi and former senior resident of PGI Chandigarh. Now, he is at present the president of All India Rhinology Society, and under his leadership, this time, ARS is going to conduct the RhinoCon. I think it will be 37th RhinoCon in Guwahati. Now, he has done more than 1,300 cochlear implant, and he mentored many institutes in national and international level. He received many awards, notably state level merit award for the work in the field of deafness by the Honorable Chief Minister Didan Srimati Vasundhara Raje Scindia. He has got more than 100 national and international publication. And he is the chief editor of the textbook of Radiology of Cochlear Implant by Thin publication. Is the editor advances in implantation of otology in Stranger's publication. His hobbies is photography, tennis, travel. And in the last, our NEBAOI classroom, Professor Manish, he narrated the excellent your middle year anatomy and the ear anatomy particularly, which is done by Dr. Anuradha Deka from the GRIMS, and we are all thankful to the speaker also and the moderator also and the external expert also and all the participants, those who have been participated in that. And today we are having a very important topic, that is the CT scan of the temporal bone and particularly mastoid. And I hope that it will give a very, very important information to all of us, particularly the PG student, because they will be appearing in the exam, I think, in the month of August this year. So I hope all our junior faculty and the PG students, even us also, will get enormous information today. And I welcome you all again. So over to you, scientific chair.
Thank you, Dr. Shubhamoy.
So now I'm going to introduce Dr. Kesavananda. Kesavananda Kaur is known to all of us. So presently, actually, it's nothing to introduce newly. But for the sake of introduction, I will tell a little bit about Dr. Kesavananda. He is presently he is the senior consultant in the Department of ENT and Skull-based Surgery, Sukafa Hospital, that is in Shivsagar, and his interest is in anterior skull-base and airway surgeries. He is a pioneer. Actually, he has been pioneering in lot of subjects. Like he started the cochlear program in the Sukafa Hospital, Shivsagar, and he started the hearing screening program in Sukafa. And he again started the anterior skull-base surgeries in the for the first time in the Upper Assam. So today's topic is very interesting because every time we talk about the CT scan of the temporal bone, we learn new things. So definitely Dr. Kesavananda Kaur will elaborate the temporal bone anatomies that is related to the middle ear infections. And with Dr. Manish, we will be able to learn a lot of new things today. So I welcome Dr. Kesavananda for this deliberation, and I welcome you all. So next, I think Hirana Baidu will.
Yes. Good evening, everyone. Today, I welcome Dr. Smiti Rupa Datta. Smiti, are you there?
Yes, Baidu, I'm here. Good evening, everyone.
Good evening. Smiti Rupa Datta. She is professor and head of the Department of ENT, Silchar Medical College. And I welcome her as a moderator for today's session. She received the S. Kumar Award, L.H. Hiranandini Award, and she has 35 publications in national and international journals. And she presented few research papers in SARC Conference 2010 and presented research paper in PAFERS Conference in 2024. Again, I welcome Dr. Smriti Rupa. Secondly, next I welcome Dr. Biswajit Gogoi.
Good evening, ma'am.
He's a well-known name in NEBAOI. Yes, he is a prominent ENT surgeon and one of the cochlear implant surgeon of the Northeast. I welcome Dr. Biswajit as moderator for today's session.
Thank you, ma'am. Thank you, ma'am.
The next, I think the speaker's speech will start. Dr. Kesavananda, please start your session.
Thank you, ma'am. Okay, so I hope good evening, everybody. My screen is visible to you all, and I'm loud and clear.
Yes, visible.
Go ahead.
So today we will be discussing regarding CT temporal bone in relation to the chronic otitis media. So I'll briefly, because I was given the topic at the very last moment, so I have just briefly made a presentation. I hope I have given enough justice to the presentation. So please excuse me if there is any, if I felt short in terms of certain descriptions and all. So when we talk about CT temporal bone, so what do we need? What are the areas of interest? What do we need to see in a CT temporal bone? In terms of a chronic otitis media, we need to have a localization to visualize the pneumatization of mastoid, the extent of disease, the tegment tympani erosion, sinus plate erosion, facial canal dehiscence, lateral semicircular canal dehiscence, any disruption in the ossicular status, and the disease progression outside the middle ear cleft. So these are the areas of concern which we as a otologist need to understand before we proceed. So many otologists may also say that we don't need to go for the CT scan for chronic otitis media cases, even though it is a cholesteatoma, or seeing with the clinical picture, we can go forward with that. But I would say in today's scenario, CT is a very much good roadmap towards the decision making of your surgery and how to proceed about the particular disease. So what we do is a basic, this is the basic technique of how a CT scan of temporal bone is done. It is usually once it's a dual field view of 100 mm section is taken with a 0.6 mm slice thickness. So serial axial sections are taken. So once the sections have been taken, they are distributed to 3 orthogonal planes in the axial, coronal, and sagittal planes. So once the sagittal data is obtained, so at the sagittal data where the anterior and posterior limbs of lateral semicircular canal are displayed in cross section. Here in this section, we can see there are 2 dots here. These are the lateral semicircular canal, where that is the plane. Once that plane is obtained, the lines parallel to that plane is made in the sagittal section, and along that plane, the axial sections are serially made. And the coronal sections for that reconstruction, what is done is that the line perpendicular to the axial sections which have been made in the along the lateral semicircular canal, the sections are made exactly at perpendicular along to reconstitute the coronal planes. So in that way, we get both the planes together. And it is very, very much essential to observe each sections in different ways. So what we obtain here is once the sections are made, it's a 0.6 mm thickness image thickness by 0.5 mm the distance images. So these data are then recollaborated and we observe in different series. So first of all, in briefly, what here we see on the left side of the picture, it is an absolutely normal, well-lemmatized mastoid, and in the other side we can see there is a sclerotic mastoid. So how do we differentiate between a squamous cell disease and a mucosal disease? So what is important here is the differentiation is when both occurs in a poorly nematized mastoids, but we have to look for the bony erosions, erosion of the lateral of epitympanum, the ossicular chain erosion, and in certain cases also in chronic otitis media, the erosion we may find this erosion, but it is very less in terms of chronic otitis media. The displacement of ossicular chain can be seen in cholesteatoma and not in chronic otitis media. So cholesteatoma can present as a non-dependent mass, while chronic otitis media we see thickening of the mucosal lining. So in both the diseases, the middle ear cavity is completely opacified. So first and foremost thing which we are as otologists are worried about is the facial nerve integrity and its normal course during which we may encounter during the surgery, most often which we are feared of. So we need to understand how it travels from the IAC till the stylomastoid foramen. So this is just a diagram. So on how we correlate in a CT scan. So in this, there are both the sections we have to observe. In the left side, we have the axial section, and on the right side, we have the coronal section. So in both the sections, we can see the beginning of the IAC at this level on the right coronal section, and we can see that it just curves around with the above the lateral semicircular canal. So here in this section, I will show here. Yeah. So here you can see that the whole nerve, the cranial of the labyrinthine segment, it curves around the anterolaterally over the top of the cochlea, and just at that this is the first genu, and it completely comes posteriorly, crossing at that side to form the tympanic segment. So here we have to correlate as you see in both the above the axial section and in the coronal section. What we here see it is the genu, the first genu over here, the labyrinthine segment. Here we can see how the arrow points the bend over there. And here after the genu, it forms the tympanic segment. Here on the coronal section, you can see there are two tiny dots. It is at this section, what we observe is that as the nerve is coming again posteriorly, so we can see the two tiny dots, the curve which forms, it is one is the labyrinthine segment, another is the tympanic segment. Just more laterally is the tympanic segment. So once it comes down at the level of the oval window, here we can see the mastoid segment is completely visible here. And here what we see is the pyramidal eminence, which is medial, and the sinus tympani is medial to the mastoid segment, and facial recess is lateral to the mastoid segment. Finally, this is here we can see the tympanic segment is coming down here, and here at this point and the axial section, you can see that the origination of the greater superficial petrosal nerve from the first genu. So once it comes down, exits through the tympanic segment. It exits through and it forms. It enters to the parotid gland through the stylomastoid foramen. Here we can see here on the coronal section, it is the whole facial canal coming down. So and then next comes is the jugular bulb. So this is what the next picture, what we need to understand is that the reason here is we may some abnormal variations in the jugular bulb, like the high jugular bulb. So when the jugular bulb rises above the lower limb of the posterior semicircular canal, Okay, so if it reaches above the posterior superficial canal, it is called as a high jugular bulb. So if the bone is separation between the jugular bulb and the tympanic cavity is absent, it is termed as a dehiscent jugular bulb. So we need to understand, because during surgery we may encounter, we may find a dehiscent. We have to pre-operatively, we have to understand the position of the jugular bulb. And rarely, sometimes there is an outpouching seen in the jugular bulb, which is called as the jugular bulb diverticulum. As here you can see, there is an outpouching here in the coronal section. So this is a jugular bulb diverticulum. Sometimes in sigmoid sinus also we may find some kind of diverticulum that here at this level. So another thing is the bulging sigmoid sinus. We need to identify the sigmoid sinus position, because sometimes it is very much anteriorly placed. In this case, it is already post-operative case, but you can notice that how anteriorly the sigmoid sinus is placed, because during the surgery we may injure the sigmoid sinus. So we have to be very careful. So now we will just go into the disease thing, the chronic otitis media. So here we can see in the CT scan, how does it helps? So sometimes it usually, in the simple otoscopic findings, we may find an intact tympanic membrane, or thickened tympanic membrane, but the patient may be complaining repeatedly here discharge, and that the disease is not resolving. So in that case, we may see, if once we may order a CT, then we may find some thickening behind the scutum and between the ossicles. So that thickening and which is there, it suggests of chronic otitis media, but because there is no bony erosion, so we can assume that this is not cholesteatoma development going on there. And another beautiful finding is that the calcification of the tympanic membrane. This is a simple tympanosclerotic patch we may find in otoscopy finding also, and this is a thickening which is beautifully designated, is shown here. So this is one more CT where there is a recurrent otitis media, a grommet. Here we can see that because this grommet has been placed here to relieve the persistent otorrhea. But what we see here is the whole mastoid area is well nematized, but it's all coalescent. There is all mucosal thickening over there, and the middle layer is all filled up with fluid and soft tissue. But there is no as per bony erosion we can see. So in cholesteatomas, what we see is they usually represent as a small soft tissue. And here what we can see in the left side, you see there is a small soft tissue over with the erosion of the scutum. So what happens with the cholesteatoma is that it depends upon the size of the cholesteatomas, the extension of the disease, which shows the different various kind of erosions over there. But the most affected structures with the cholesteatomas are the ossicles, the long process, lenticular process of the incus, and the wall of the lateral semicircular canal, lateral tympanic wall, that is the scutum. So usually in CT scan, we can see a soft tissue mass between the ossicular chain and the scutum, which is usually eroded, which is diagnostic of the cholesteatoma. In the same picture, here we can see that there is a soft tissue density here, just lateral to the ossicles. So this cholesteatoma has eroded the scutum over here. So what we see here is that there are two ways of how cholesteatoma behave. There's a pars flaccida cholesteatoma. The lesion starts anterior superiorly in Prozac space, the area, and it just extends laterally toward the ossicular chain and into the epitympanum. But pars tensa cholesteatoma, it begins posterior superiorly and extends posteriorly towards the facial recess, tympanic sinus, and then medially towards the ossicular chain. So these are the two patterns how cholesteatoma may spread. Here also we can see there is the erosion of the body of the incus is seen, but the lateral head, which is lateral to the malleus, the head is also eroded here. There is a soft tissue mass in the middle layer in the procex space. There is a bony erosion of the scutum, lateral semicircular canal, tegment tympani, long processus superficial. So sometimes the facial canal dehiscence may be visible in a CT scan, but very thin but not, it is not always visible. Sometimes even if we are a soft tissue thickening over there may kind of mimic facial nerve dehiscence, but on OT table when the para you may not find the kind of dehiscence which we are expecting, but in terms of a very limited disease, not in a very extensive disease, you may find that may be completely correlated with the CT scan. So this is a patient here with a hearing loss, unilateral hearing loss. Here we can see there is a soft tissue mass in the long process of the incus. So it is there is and there is a well aerated mastoid, but the soft tissue mass is there, which is suggestive of a cholesteatoma. Here we can see there is an erosion of the lateral semicircular canal, which is with a, and on this section, on the coronal section, we can see there is thickening of the eardrum and there is a retraction pocket over. And again, this is a patient with a left-sided retraction pocket and otorrhea. It shows that there is some erosion in the long process of the incus and the stapetal superstructure. So these findings well goes well with the kind of cholesteatoma, but parop there was no cholesteatoma found. A post-operative patient may present with recurrent vertigo, so we may suspect there may be some erosion to the semicircular canals. So while doing CT, that you can see there is an erosion in the lateral semicircular canal. A recurrent otitis media patient presenting with a recurrent otitis media on CT scan, it is if you may find that well aerated in a mastoid cavity, the TM may be in otoscopy find is maybe thickened, but on CT scan when we see there is a soft tissue mass and which is particularly just displacing the ossicular chain over there, and it is hanging and is not coming down. So this is completely typical of it may be a cholesteatoma because there is a displacement of the ossicles. So finally, I will just conclude with this slide. This is one of the studies that was done. So I've just taken up the slide, which shows in 30 patients that how CT scan is helpful in the sensitivity and specificity in terms of diagnosing of cholesteatoma, bone erosions, ossicular erosion, mallear erosion. So what we to conclude with, I will say that CT scan is just not the roadmap only, but it is to understand the disease in terms of disease progression, in terms of disease prognosis, that how much we can define the disease and how much we can promise the patient that what is going to happen with the hearing status and post-operative care of the patient. Thank you.
Thank you, Dr. Keshav. May I request Dr. Monish? Dr. Monish,
Yeah, good evening, ma'am.
good evening.
Okay, wonderful. I love the details of the chronic otitis media, because CT really forms such an important thing. Like last time, I was also trying to jot down a few things as to how we can look at the CA temporal bone better. If I could just share my screen once.
Yeah, please.
Rohan,
Then-
please.
Okay, is it visible?
Yes.
Yeah.
Okay, wonderful. Like, I think one of the first slides which Dr. Keshwanan showed was how do you decide the axial and the coronal planes, right? Because, majority of times we think that axial is the true horizontal and then coronal is a true vertical. But in temporal bone CT scan, it's very different. Now, a true horizontal would be the Frankfurt planes, which is the superior border of the external auditory canal and the inferior border of the orbit. And this is the Frankfurt plane, which is the true horizontal. Now, the axial sections are, in a simpler manner, is simply at 30 degrees to the pure axial, right? And this 30-degree angle is there so that we see the lateral semicircular canal as a signaturing appearance. So we are seeing it in a complete entirety because it's a 30-degree to the true horizontal, right? And so that's why we can see the whole semicircular canal in one single section. Similarly, the coronal planes will be perpendicular to this axial section. So they are at 30 degrees to the pure vertical. And there you see, the superior semicircular canal, one limb running completely up, right? So this is how you kind of place these axial and coronal sensitive temporal bone. Now, one of the other sections which I always want to see, and I ask my radiologist to get it done, is what we call as a MPR reconstruction, and you get a double oblique coronal, right? And the reason I ask for this is because this is one single section which shows you everything which is important to you, especially with respect to cochlear implants. Now, if somebody can, let me just kind of go about telling this is, we can see the whole of the cochlea here. You have the vestibule, the superior and the lateral semicircular canal. You have these two dots as the labyrinthine and the tympanic segment of the facial. Then the rest of the tympanic segment, the second genu and the vertical segment. And you have the oval window and round window seen directly here. And inferiorly you have the jugular and the carotid seen. Right, so no other section would show you everything in one single go, which is what really makes it so beautiful. So this is just the colored part of it again. The cochlea, the vestibule, the oval window, the round window, the labyrinthine segment of facial, the later part of the tympanic segment, the genu, the vertical segment, the jugular and the carotid, right? It's a very beautiful section to look at. So if you can just ask a radiologist to provide you with an MPR image and do a double oblique coronals, it would easily give you what you need to, right? So it makes it very easy for majority things to understand. Another thing which is very important is, many times when we have a look at the scan, we need to be very sure if the scan is really good enough or not, right? There'll be a lot of scans which are provided, which are really worthless to look at. So the important point here is a few features which are so important to see. For example, if anybody in the residents or the senior residents could comment on what is this line which you are seeing here? You see this arrow which is pointing towards this line, right? I hope this is visible, right?
Yes.
This line. So can any of the residents or senior residents really, give their opinion on what this is? Because this is one of the landmarks to really say that yes, it's a well done CT scan. So is anybody of them there?
Yes, yes.
Okay, does anybody want to take a chance with this?
Stapedials.
That is the petromastid segment. Petromastid segment, sorry.
No. So this is,
On that line.
this is your internal acoustic canal, right?
Okay.
This is in the inner ear part. This is your middle ear here, right? So this is the vestibule. This is your cochlea, and this is
aqueduct.
yeah. So this is actually the internal acoustic canal, and from that is arising the singular nerve.
Singular. Oh.
That's your singular nerve which goes in, and if you're seeing this on your, even if it is slightly seen like this versus this, I'm okay. But you really want to see this coming separately. If this is done and seen, then it's a very good CT scan to look at. Similarly, if you look at this section, if you could faintly make out the outline of the stapedial crura, right? This is something which then would tell you that yes, you are looking at a good quality CT scan and it's good
Yes.
enough to, kind of read your CT images. So just a few landmarks. Now, when you talk about chronic otitis media or cholesteatoma, ideally a cholesteatoma is seen as a non-enhancing mass, non-dependent, which is causing any bony erosion, whether ossicular or the temporal bone. However, a CT temporal bone cannot distinguish between a cholesteatoma, granulation, fibrous tissue, mucosal edema, or effusions, because all of them look the similar gray shade, right? So, to really be sure that you are dealing with a cholesteatoma, you need something else. Okay, let's again go back to the senior residents. What can you do to distinguish between these five things? Or let's say, how can you be sure you are dealing with a cholesteatoma? Is there any way to find out? Okay, are there any senior residents who want to take this? Now, what is interesting in this is because also it becomes very important if you're doing something like an intact canal wall or a canal wall reconstruction after a mastectomy, and the antrum is therefore now not visible to you on inspection, right? So you cannot distinguish fibrosis in post-operative period from any recurrent or residual, which is so important because otherwise if you have a disease in the antrum, it would keep growing, and because the canal wall is intact, it would kind of spread intracranially rather than coming out, which is a very risky thing to have. So you need an MRI temporal bone in such cases. If you really want to confirm, you want a DW MRI, that's a diffusion weighted MRI, and then go about getting a non-EPI DW MRI. So the best imaging, one of the best imagings is get a non-EPI DW MRI if you really want to be sure whether it's a cholesteatoma or let's say granulations or fibrosis or fluid, right? So this is what you need to get it done. Now the recent advance beyond a non-EPI DW MRI is to get an ADC mapping done, right? An ADC mapping, your radiologist can give you the value, that's an average diffusion coefficient, and they give you a value of every soft tissue. And if the value of this soft tissue is in between this range, then that means you are dealing with a cholesteatoma. Now, let's look at the clinical scenario. Why is it so important? We're doing more and more of intact canal walls, right? Now, this is one of those patients, right? Both the sides have been operated upon. You see this kind of a soft tissue density, which is non-dependent in this area, right? Now, it looks to be pretty similar on imaging. You get a DW MRI done, that's a EPI image, that's a non-EPI image. Look at the left side here. This is where it's showing diffusion restriction. This is called as a diffusion restriction. So it's a non-EPI or an EPI. You see the non-EPI is way better. So the non-EPI DW MRI tells you that the left side actually still has a cholesteatoma. Right side could just be some opacification because of fibrosis or edema, right? So this is so important now that every intact canal wall of ours, after a period of initial 6 months, goes and gets a non-EPA DW MRI, and then after 1.5 years. So that's a follow-up which we do instead of taking a second look surgery. We just go about doing this, right? So this is just a brief thing which I wanted. Other thing which you can always have is to have something like this kind of a software. Go back to your console rooms in your radiology department, and you need to look at the axial coronal sagittal in all in one go together, right? And why I love this software is, we can go superiorly and inferiorly, look at every section. Now, if I were to see it in a hurried manner, and the other beautiful thing is, it doesn't just keep it black and white, it makes it all colored if you want. So these two green dots are the superior semicircular canals, the anterior limit. I will not take a lot of time here because I don't want to keep on teaching the whole. Just respect the time limit for everyone. This pink line is the posterior semicircular canal which is coming in, forming the crus commune. This is still the superior canal. This is the posterior canal, crus commune with the superior canal. Then you have the internal acoustic canal. Internal acoustic canal, let's just look at how it really looks like on our CT scans. This is your internal acoustic canal. That's your labyrinthine segment of facial, the genu, right? And then you will have the tympanic segment coming here. You have the late vestibule and the lateral sensory canal appearing here. This is where you see the whole signet ring appearance. And this is why, when you do a enterostomy, you do a cortical, you first landmark you see is the bulge of this lateral sensory canal. Anteriorly, you have the cochlea, the facial nerve labyrinthine segment in between, the first genu, and then the tympanic segment. Inferiorly, this is the very good thing. So if in your exams, the examiners are very fond of asking where is the facial nerve. And one of the best things to look at is you look at the ice cream cone appearance. This is very easy to identify. And if you're seeing the ice cream cone appearance, in the same section, you will always see the tympanic segment of the facial nerve. So one of the easiest way to identify the facial nerve, look at the ice cream cone appearance, look at this line, this is your tympanic segment of facial. More inferiorly, just in a hurried manner, the facial nerve now disappears, however, you still have a soft tissue density present here, and this is nothing but a tensor tympani muscle. So tensor tympani is coming from anterior wall, processus cochleariformis, hooking up, going towards the malleus. This is how it really goes, right? So this is where you see it. You have your vestibule, you have your sinus tympani, this is your vertical segment of facial, this is your posterior semicircular canal, and you will also see your stapedius crura here. Right? So stapedius crura connecting with the saccule, and then the rest of the cochlea comes in here. If you want to go inferiorly, you will be able to see the pyramid and the stapedius muscle going towards the stapes head, right? Look at the landmarks again, the various turns of cochlea. You have the round window present here. You have your carotid, the eustachian tube. This is your eustachian tube. This is your tensor tympani, sinus tympani, pyramid and the stapedius muscle, facial nerve, and the posterior semicircular canal, right? So makes it very easy if you look at it from this point of view. Every section is in front of you. And these are the various parts. The carotid and jugular will now start coming together. Remember, this is where a eustachian tube is so close to the carotid. And that's why, my teachers always told me, do not use any sharp instrument near the eustachian tube. Because if you do that, you may damage the carotid, right? So stay away. Anterior wall of middle ear, remember, we saw it in the last class also. You have your tensor tympani anteriorly, you have your eustachian tube anterior. These are two openings in the anterior wall, and you can see it so well on the radiology, right? So this is how you can actually go about looking at those things. Keep moving inferiorly. This is where you see the cochlear aqueduct now. So cochlear aqueduct comes from posterior part and goes and attaches to the scala tympani of the basal turn. It's rarely patent. It's usually closed. So this is again closed, and you don't have any issues. But now the cochlea and the jugular are coming together. Remember, the anterior one is always the carotid and the posterior one is the jugular. So even if you're seeing two of these things, remember the anterior one is the carotid, the posterior one is jugular. And that's where I finish. I think, there are a lot of things in radiology. It's a lovely talk to be happened, and I'm really very happy with the way I think Dr. Keshwanan talked about the chronic otitis media, because that's something which we see day in, day out. And now the imaging for temporal bone CT is increasing a lot, especially when it comes to chronic otitis media. So thanks, Dr. Keshwanan, and I hope I could, make some points clear, which I really wanted to.
Thank you very much, Dr.
Thank you.
Monish. It was great listening to you. Now, may I request our moderators, Dr. Bisho and Dr. Smriti? Dr. Smriti?
Good evening, everyone. Well, it's always very lovely to listen to Dr. Monish, our expert here tonight. He touched upon very important clinical tips, and I believe the residents and the PGTs who are here in the webinar have really gained important points to answer in the equation in their exams. And thanks to Dr. Keshavananda for presenting your beautiful presentation here. And today's topic being chronic otitis media, we all know it's a chronic disease, and it leads to, since it progresses and leads to several structural deformities, and then leads to several functional deficits too. So radiology, I mean the HRCT, temporal bone, it really plays a very important role. Because it helps in several ways. Number one, it helps in not only the diagnosis, it also helps in assessing the severity of the disease. And more so, it also helps in identifying the ensuring the complications if there are any. So by looking into these 3 steps, 3 parts through the CT scan, one can plan the surgical procedure and thereby can go for early intervention and prevent the complications if there is suspected to be any in future. So in that case, HRCT temporal bone really plays a very important role. Though MRI has very important roles, but we still believe and we advise CT scan more than MRI. We advise CT scan to our patients because from CT scans we can pick up many of the diseases from the middle ear, the destructions, bony destructions, the ossicular erosions, the cholesteatoma, mastoid involvement. These are what we want, and this can be picked up by CT scan alone. So yes, CT scan is very important, and I believe this topic was rightly chosen today for today's discussion. Thank you, everyone.
Excellent, Keshav. Excellent, Manish, once again, as usual, from you. Can I go directly to the questions?
Yes.
There's a few questions, I think.
Yes, you can go.
There's a the question from, as usual, from Fukwan sir. CT or MRI? Anyone choose which one to take? Keshav.
Yes, usually we go for HRCT only as the first line of investigation.
No. CT or MRI? He's asking between the CT and MRI. Anyone, if you want to choose.
CT.
If very specific way for chronic otitis media.
CT. CT only.
Why not MRI?
It's not about why not MRI, but it will come once if I find something very it depends upon the presentation and depends upon what I have find in the otoscopy findings and what is the clinical scenario over there. If I am looking into something which is it's an aggressive kind of a disease or something which may clinically may look benign, but the symptoms may not be that much correlating with the chronic otitis media, or if I am suspecting something deeper malignancy kind of thing or something, then I will obviously go for MRI. But in terms of a simple chronic otitis media, the CT will be my first choice.
Again, Keshav, can I ask you?
Yeah.
Do you routinely prescribe the tibotympanic variety is for SRCT mastoid?
Not all cases, but yes, but those cases which are which have been chronic discharging years. Dry years, usually I don't go for CT. Although in its chronic discharging years, I go for a CT. Yes, all the time.
Manish, what is your take on this?
Okay, so chronic otitis media, the traditional teaching has been that you need not get it done for a mucosal disease, right? If it is a squamosal disease, then there are, traditionally few indications. One is a revision surgery. Two is a chronic otitis media with complications. And then if it is a pediatric patient, because pediatric patients can have a really widespread disease. Now, these are the traditional teachings, and I'm happy if the residents would say so. It's good enough. Clinically, if I look at it now, my practice has changed a lot over the last few years. I'm getting more and more CT scans for squamosal variety. I don't get it for mucosal variety at all. Squamosal variety, yes. And the reason I do get it now is because now majority of my surgeries are going inside out, right? So that I know the extent of the disease. And if there is a limited disease, I don't do an outside in. I would do an inside out and follow the disease and give a very small cavity. So that really helps me. And now I'm also being in an academic institution. It's always better to kind of teach your residents. But the major reason for me is now, if I'm doing an inside out, I need to have a CT scan. I need to know the extent of the disease, so that if I'm sure it's a very limited disease, I really don't have to give that big a cavity to the patient. So yes.
on CT basis, you always decide you are going with inside out or outside in.
Yes, a lot actually, a lot. In fact, tomorrow itself, we have a case which we have posted, and our senior resident Dr. Ambika, who has also joined this, this event which you have organized. And she herself showed me in the morning that, we have a very limited disease for this patient. So we'll probably land up doing an inside out. And, this is what makes you feel happy, because your CT really does guide you the approach towards the surgery. And so for me, it's like almost all the patients of a squamous cell variety now undergo a CT scan, which was not so maybe till maybe 3 or 4 years ago.
That's a great point. So the second question is here: soft tissue window or bone window in a temporal bone CT. Kesav, you try to click on this question.
It's a bone window.
Asking between soft tissue window or bone window in temporal bone CT.
Usually we go for a bone window only. I say what Dr. Monish is have anything to say.
Yeah. The first thing is the bone window. You don't get to see anything on the soft tissue window for
Yes.
temporal bone. The only reasons when you can get a soft tissue window also is you're looking for something which would be invading in the soft tissues. For example, a skull-base osteomyelitis. If you want to see if it's coming in the preauricular space into the parotid areas, then you need a soft tissue window. If it is a case of malignancy, right, you would again want a soft tissue window to see the soft tissue involvement which is present, right? So it is only in those conditions when you're really looking for any soft tissue involvement that you get. Otherwise, it's always a bone window for a seriotemporal bone. Right? A soft tissue window will not tell you anything at all. It's a complete waste for majority actually.
There's a comment by Kamalika. I don't know what she's trying to understand. Bill's bar. Maybe it is a landmark during the. She wants to know about the Bill's bar during CT evaluation. And the Vasusi, there is a question for DWMRI. Vasusi, can you unmute yourself? Can you ask the Manish directly what you want to ask? Please communicate.
Oh, it was
Vasusi.
the answer to his question, actually.
No, sir. Actually, it was the answer to the question which sir was asking, like when to go for the CT scan or MRI, like in the following cases. Yes, sir.
Yeah. So you are absolutely right. The only thing which has changed now is it's obviously the DWMRI and you get a non-EPI imaging done for it. The ADC map is something, which would be good fun to get. If you can get an ADC mapping done, just ask your radiologist to give you the ADC mapping. It would be really wonderful. It's a good tool to have.
So I just want to ask one thing, sir. So like in case of mucosal diseases, so when do you actually go for CT scan? Is there any indication, like if the hearing is like mild to moderate and also like, is there any like...
The only thing is, Dr. Keshwanan mentioned, if it's a persistent discharge and if you're suspecting something else going on which is really not improving, only then you may get it. Otherwise, no. Unless rarely you may have a complication out of a mucosal disease, which is again not seen. So very rarely do you get it. So if it's a persistent discharge, not improving by anything, then you may get it done, or a complicated, safe mucosal disease would again be requiring a CT. Otherwise, no.
Manish,
sir,
is there any regarding the medical legal point of view?
Not as of now, sir. But let's assume, if we damage anything, if there's a fistula present, many times a fistula may not be, diagnosed preoperatively clinically, right? And if you don't have a CT scan, you might miss it and you may damage a few things. And then to prove that it was initially present also may be difficult. Yeah, as of now, actually now the guidelines in our country mention that it's mandatory.
Yeah, exactly.
To
There is no guidelines, right?
No guidelines.
There is no guidelines.
So,
but
no medical legal issue.
I am afraid in future, whether both in mucosal, inactive mucosal also, or active mucosal, forget about the squamous cell, whether CT will be a mandatory option for that to get rid of the medical legal point of view.
You see, sir, US and even Egypt, so they get it even for a mucosal variety.
Exactly.
Which I think is an overkill.
Yes.
But then we may also change after a few years. As of now, no. But yeah, so people abroad are getting it done.
Yes.
So I do completely agree with that.
In Fukan sir, you have a question. I think Fukan sir can unmute yourself. Fukan sir.
Yes, come.
Yes. You have a few questions again. Can you ask directly to Keshav or Manish? I have found you have a question regarding any molecular marker helps in revision surgery. That's the question.
Experience
for,
with that. It's all
Like
theoretical
a
for
jealous.
me.
okay.
I didn't get the question. What was it?
It's
Any
any molecular marker in
helps
terms of a recurrent disease or residual disease
Oh yeah. So
or
KI67.
cholesterol.
KI67, right? So you can
Yes.
get it done, and that would actually guide you as to the severity of the disease and the destruction it can cause. And if your external canal skin also shows a high expression of KI67, there is a higher chance of it probably being more aggressive, right? So it's more aggressive if the KI67s are high, and that can be extrapolated that it might recur. But for a good surgeon, you can't really get out of it by saying that this patient had high KI67. No, that doesn't work out. But so ultimately, it's your surgery is what is important. But yes, if a patient has a high KI67, that means a more aggressive disease.
Yes. More elusive.
But how routinely you practice it about like
No,
No,
it's
no.
not only it's only
Academic.
for
Academic.
Yeah, it's only for academic and research that we got it done. We had a thesis project at our place. I think AIMS also got it done, and so
Yes.
that's been proven. But it's just for academic, right? You cannot predict a recurrence just by KA67 per se. But just because you asked, I mentioned that. Otherwise, no.
yeah.
In fact, many people will not even get a biopsy done. So forget getting a KA67 done. Right?
Again, concerns a very micro kind of questions. How will you differentiate between fibroadhesion, hyalinized adhesion, osteofibrous adhesion by imaging?
So it's got to be MRI. Theoretically, if your radiologist on the CT image can look at the Hounsfield units, then they may, but that is practically impossible. So you need an MRI for this. So it's got to be an MRI, nothing else.
Very practical question by Anjanda again. What is the extent of the disease in CT that indicates outside in nephros? He wants to classify between stage of the disease where you can decide now I'll be this case with the outside in.
So for me, it's if my canal wall is being eroded, it would be an outside in. Or
Before
if
disease.
if it's the canal wall, the posterior canal wall erosion, or if it is reaching really near the cortex, and I can really see that it's an extensive disease, there is no septation left at all. It's a big cavity seen. You may as well do an outside in here. Then it doesn't make sense to go inside out. So if it's a big cavity seen, canal wall erosion, disease coming more towards the cortex, yeah, go with an outside in. Right? There's no point doing inside out there.
Okay. So Movesh, your question is already answered by Keshav. Mucosal disease, yes. Already Manish has also explained that question. And the question from late the questions comes in the set box. Then I have a question to Manish. What is the software you are showing today for the juniors actually?
Oh yeah, this is a beautiful software. I got it when I was in Stanford, and in fact I got it for temporal bone, PNS, and even neck. But what has happened is they've started upgrading it. So now PNS and the neck don't work, and probably with my Mac it's not suiting. But if you want, I can mail you this software, and you can try. It's a beautiful thing to teach,
Is it a
and
free access or
it
it's a
is free
classified?
access, but only if it really works on your it's free access otherwise, but it's not easily available now because they used to. And this is like I got it almost 15 years ago, and as I said, the temporal bone, other than temporal bone, the neck and the PNS don't work for me now. This is the only one working, but I'll mail it to you. Try it out if it can work on your laptop. It's one because based on the configuration of your Mac and I use a Mac and it's been working on Mac this configuration, but the other two are not working for me. So I can just mail it to you. This
Please
has been
share.
pretty
I'll try
fast.
once. Please share. I'll
Yeah, I'll
try
do that.
once. But it's nice
I'll do
because it color grading and all these things.
that. It's
It's
lovely.
very good for academics.
Yeah,
I don't
Absolutely.
lovely.
the clinical practice, but it's lovely for your academics things.
Yeah, absolutely.
It's a great. I think it's a great tools for academics. The next question has already arrived by Biplab
Love
now.
that.
What is the rule of CT in autosclerosis? I think it's a. I can actually Manish can talk on one day on this question.
I know. So now I don't do a piece surgery without an HSA temporal bone, right? And there are so many classifications to it and gradings which exist. and it's something which is, which is beautiful to see. If you can see it, you are so confident about it when you go inside. So, and medico-legally, I think it is more important here because, you can damage hearing in a tracheotomy. So if you've already proven that it's an extensive disease, you can even look at the thickness of the footplate if it is a well-done CT scan. So yes, for me, every patient where I'm suspecting autosclerosis, there's got to be a CD temporal bone. I don't go without that.
Yeah. Yes. This is the kind of a dictum. Okay.
Absolutely.
For the Keshav, can you share some software for the junior colleague? I think today is a great day for us because we have a 40 plus participants. It's a great
50, Bishop, 50,
it's a great
50.
things. So
One time it was 50.
but it's very essential to have a software to see all the actually you have a when you prescribe nowadays for city
Speaker.
always have a intention to write please provide the city along with the
Yeah.
report so that you can
Yeah.
everybody can discuss, the whole team can discuss. And the next thing is that you have the already DICOM file in your, then you can go with a study. But can you provide the software, what is the basic software available, if there's free software also who can start this study? Anyone get that question? Like because money is software is a very classified software. It is not available for all.
I know.
But
Then a
I
free
think there's
software is
lots of
available, the Radiant DICOM viewer, which is freely available, which is, it comes with a, a registration period kind of a 60 days, but it can be renewed on freely. You can go through it. It's a very good software.
I think this is the best software available free. Of course, you have a paid version also.
Yeah,
You can
paid
go with
version
the
is
paid
there,
version also.
but free
Because
version
free
works very well.
both, there's a micro DICOM also, micro radiant DICOM also. That is also very good. Go with a mobile also sometimes.
So there's
And
a question in Dr. Biswa. From Dr. Mubiz, is there any finding in CT that suggests impending intracranial complication? That's from Dr. Mubiz.
Okay.
It's just if you see it to be too many erosions which are happening, going more towards any of the, if it's showing a lot of erosions, then it may be pointing, if you have the posterior fossa which has been eroded or tegmen which has been eroded, that just indicates that you have an impending intracranial thing, but it may still take many months before it happens. But any erosion of the tegmen, erosion of the sigmoid sinus plate, erosion of the posterior fossa dura, you can, probably lead to an impending intracranial complication.
Yes, but if you're suspecting intracranial complication, always
MRI.
there's low threshold for MRI. There should be a low
MRI.
threshold for
Absolutely,
there should be
yes.
always low threshold for MRI.
So clinically, if there's no suspicion of intracranial complication, we can stop at CT. Otherwise,
Absolutely.
Otherwise, MRI.
Absolutely.
Because MRI will give us good result about the intracranial complications.
Oh yes, yes.
Since we have 2 more minutes to end of the session,
Yeah.
I think.
Anybody has any question?
Question, then you can unmute
Anybody
yourself,
has
and it's a great chance to
unmute and put your video on.
What a great
Any question or anything, anybody want to share anything, you can share, and there's no.
yes.
I want to ask a question. Hello.
Yes, sir.
In third window syndrome, suspect I got clinically. I am suspecting a third window. How to I can advise the radiologist to the view, process view, or some views like that. Because all radiologists are not versed with this third window.
Okay, let me share my screen for this. I love this question. So sorry. Okay. Can you see my screen?
Yes.
If if you're suspecting a third window syndrome, and let me take that as a superior semicircular dehiscence, because that's where it's most commonly mentioned now, then you need to get 2 planes done. This is the plane of Stenver, right? Plane of Stenver would be when it is perpendicular to the course of superior semicircular canal, or let's say, kind of running parallel to the petrous apex. And this is how your superior semicircular canal would look. If this is covered by the bone in the Stenward's plane, there is no third window. If there is a dehiscence present, as you can see here, the third window. The other cut which you see is the plane of Poshkal, which will be perpendicular to the petrous apex or parallel to the plane of superior. Now, this is how you see the superior scan normally, but if there is a dehiscence or a third window because of this, this is how you see it, right? So there are two planes which you need to get done, Stenwars and Poshkal. So,
Thank you.
Just wanted to share this because this was asked, but there are so many things which are so beautiful on real. In fact, one of the latest things which I came across with this kind of a patient, and there have been a very few case reports. If you can see this, this is a dehiscent vestibular aqueduct, right? This was a vestibular aqueduct which would go in from here. It doesn't have a bony covering. So this was again a third window syndrome, which has been, very rarely reported in the world literature. But this would again behave in a similar manner because now you have an internal layer which is coming towards the pneumatized part. So this is a dehiscent vestibular aqueduct. Again acts as a third window.
When you tell you dehiscent, operculum or something like that.
Sorry?
When you call it a dehiscent, vestibular aqueduct.
It's if it's dehiscent into the mastoid air cells, right? If you
Yes,
don't have
yes,
a bony
directly.
covering, if you
No
don't have a
bony
bony
covering.
covering, only then we call it as dehiscent. It's very rare. I think only 1 or 2 cases have been reported till now. So it's not that something you would really find it very commonly. So yeah.
Thank you.
Thank you, Dr. Monish.
There is no more
Now,
question.
no more question, I hope. Anybody has
two,
any?
Two questions have come up.
No.
Please
One,
take.
Shuklima is asking that
Okay.
to elaborate about recent advances with CT temporal bone. So in terms, I think recent advances may, in terms of not only CT temporal bone, but in radiology, the AI has come up with a lot of things. So recently AI's work is also going on. I think Monish will be in touch up in recent advances in terms of AI and all. Anything?
A lot of things. Now there are a lot of AI software which are reporting your CT itself. They're all in research phase, right? And I'm sure in maybe a couple of years it will be all be an AI reported thing for us.
AIMS has already started reporting AI reports only.
Yeah, but they're doing it for a chest X-ray right now.
Yeah.
They're not doing it for a CT temporal bone, but yeah, just a matter of time, I suppose.
There's one question. Is there a contraindication of CT scan in mastoids by Dr. Nibaran Sharma?
Is there a standard contraindications for any CT scan? If otherwise there is no specific contraindication for a CT scan. It's a plain CT scan.
Yeah.
Okay, thank you very much. This is now my part to give vote of thanks. So, the respected president, esteemed faculty, and dear, can you hear me?
Yes.
Yes.
Yeah, respected colleagues, on behalf of scientific committee, sincere thanks to our esteemed expert, Dr. Monish. It was a very insightful talk and enriching session of this city temporal bone of otitis media. I extend my gratitude to Dr. Keshavananda Kumar for the excellent presentation at the last moment, and to our president, Dr. Shubhamoy Chakraborty, and Honorary Secretary, Dr. Anjan Bhuya, for their guidance and support. Special thanks to our moderators, Dr. Smriti Rupa Datta and Bishwajit Gogoi, for conducting the session and giving their inputs so effectively, and to all the participants for the active discussion. Thank you everyone for making today's NEBAOI classroom successful. It was really very useful discussion and fruitful discussion. I think everybody is benefited, especially, and thanks Monish, your residents have joined here, no?
I don't know,
Hello.
maybe a few of them, I'm not sure. Because I just gave them at the last moment. I'm not sure if anybody joined. I'm not. But this was a wonderful thing. I think if you can allow, they would love to join in.
Yeah, they can.
Yeah, definitely.
They can.
There is
They can.
no confusion on that one.
Yeah,
Perfect.
we will
Thank
share
you.
the Zoom
Yeah,
link.
so I'll share with them then. Thank you.
Yeah. Thanks you.
Thank you so much, ma'am. Thank you, sir.
Thank you.
Thank you very much.